I'm gonna try to hurry because I got a couple of people I want to talk to you for a minute about a couple of objectives. Okay, guys, this is something that you need to be familiar with, is the oncological emergencies. And like I say, that's not necessarily on the objective as such, but we're including that. And so in your book, it goes over each one of these for you. Plus, on your key points, there's a few little quotes about it, little things that just kind of explains it a little bit. But I'm going to go over them with you, and I'm going to keep them short and sweet too, because we don't have time to go into a lot of detail on these. But what you need to understand is there's certain things that cancer can trigger. Okay, and they can become an emergency situation. Now, other illnesses can cause them as well, but we're talking specifically about cancer here, all right? And the first ones that I kind of bunched together is going to be sepsis and DIC. Has anybody in here, well, I know you've all taken care of people with sepsis, right? Mm-hmm. Because that's the number one diagnosis that we see in the hospital, because I think they get paid more. But anyway, seriously, I really do think that.
Because it covers the treatment of any other infection, that's why.
Of anything.
That way if they have any HAIs, it's covered.
That's right. So there you go. They use it a lot. But DIC, all right, do y'all know what that is?
Bleeding out. They're bleeding out.
Yeah. Have y'all taken care of anybody with DIC?
No.
Anybody? Okay, you still may have an opportunity if it arises in the ICUs, you know, as you move forward to level 4. But this is what you need to know about that, though. There's some specific things about the DIC. Basically, it's where there's a lot of little clots that are forming in the small blood vessels. And as a result of those clots that form, the body is using up all of its ability to clot. It's using up its clotting factors, okay? And that will cause people to bleed, all right? So initially, you know, they're throwing these clots, which are blocking blood vessels, right? Okay, but that's because the body has this, what they call disseminated intravascular coagulation. That's what DIC stands for. And cancer, lung cancer and specifically, I think, can cause this abnormality and this clotting. But, like I say, because the body itself uses up its stored clotting factor, it can't clot anymore, so this person starts to bleed. So the bleeding is going to be one of the big issues for these folks. All right? Read in your book so you can understand this a little bit better. But it's called DIC, and when we add that sepsis to it, what do we think about with sepsis? What's kind of caused this? DIC. An infection that caused this. That's right. And so what do we do for an infection? How do we treat them? Antibiotics. That's correct. And you also need to think about maintaining strict aseptic technique when you're taking care of these folks. All right? So when you think about sepsis and you think about DIC, the main thing you're going to think about is problem with clotting to begin with. So the person has a lot of little small clots in their blood vessels, but after a while the body runs out of its clotting factor, so it starts to bleed. Does that make sense? Mm-hmm. Okay. And so the survival rate on this is not really good. You know, a lot of folks, unless it's caught really early, it's not real good. So watch for bleeding, you know, on these folks. If they caught it really early, and I'll just say this, and I think your book might speak to it also, but if they were to happen to catch where it's doing the little clots, and they're catching that, they might put them on an anticoagulant, you know. But then again, that's a thin line there. because once they run out of that clotting factor, then they start bleeding anyway, so you got that issue. So, I don't want to, go into too much more than that. On your little key points, it speaks to these in here. I'm trying to see. It doesn't say very much about it. It just says right here about the septic shocks, the life-threatening result of sepsis, which is a blood infection and a common cause of death in people with cancer. And some things that can cause an infection would be things like maybe a bad UTI or maybe pneumonia for these folks when their white count gets low.
It was a lady in my NYC last week. She had that, and she got it from the flu. She had the flu.
Did she? The flu.
And she
Okay.
had-
She did. Did she have DIC?
Yes, ma'am.
Oh, good. Okay. And on here, it talks about it can occur with different types of infections in the cancer patient. It's life-threatening with a high mortality rate. So that's what we talked about. And then in DIC, extensive abnormal clotting occurs through the small blood vessels. We just said that, right? And this depletes the clotting factors and the platelets. Didn't mention that. And that results in the extensive bleeding. And then the clots block the blood vessels and decrease their blood flow to major organs and such, and that can lead to death. Okay? So this does a good job of summing that up. It really does. All right. And then the next one we're going to take a look at for a minute is SIADH. Now, y'all had that in metabolism. Whenever we talk about the syndrome of inappropriate diuretic hormone.
Mm-hmm.
And see, this is something that we see in people who have carcinoma of the lung. I think it's more so, small cell carcinoma of the lung, where we see the SIADH as an issue. And also a melanoma in the brain tumors. A lot of times you'll see the SIADH show up with those types of cancers. Okay, so y'all know that whenever you have SIADH, that means that they're holding water, right? Okay. And what you need to remember about this one is that they're going to have a real low sodium. And I think maybe your book speaks to about 110 milliequivalents is about what their sodium level could get to. They could end up with seizures, they could go into a coma, they could even die from it. Okay? And so, like I say, what are we going to do for these folks? First of all, we're going to try to treat that underlying cause, whatever is causing the problem. If it's a tumor, right? If it's a small cell carcinoma of the tumor, we're going to treat it. We'll treat it with like chemotherapy. All right? So therefore, you just want to make sure that you got to treat the underlying cause.
They don't diuresis.
Okay.
So they don't get rid
And we need to restrict their water, right? And they may need a little sodium. So when you think about folks that hold on to their water like that, okay, we don't want to keep giving them. Pardon? Don't want to keep giving them more, right? Okay, so we've got to restrict their water because they got enough already. And we want to maybe add some sodium because that's depleting their sodium, because y'all know what happens with sodium, right? Water falls, right?
Yeah.
Okay. All right, so that's about all I'm going to say about SIADH. And then the next one is the spinal cord compression. And what happens here with the cancer, and reason it's an oncological emergency, is because there's a tumor that's pressing on the spinal column. And in turn presses on the spinal cord. Okay? So spinal cord compression, right? Makes sense. Tumor pressing on that spinal cord that's causing a problem. And you think about what kind of issues a person might have if that happens. Well, of course, if you're dealing with
Loss
a
of
spinal cord,
Extremities not working
that's
right.
right. You're going to have numbness, muscle weakness, those kinds of issues. Back pain. You might have any of these neurological type deficits. Now, what are we going to do for this one? We're going to give them some corticosteroids. And that's going to help to reduce some of that swelling that has caused to that spinal cord and spinal column. And then, of course, we may want to, if it's a tumor which is probably causing that compression, then we may want to use chemo or radiation to shrink that tumor. Now, surgery to remove the tumor might be a possibility, depends on where it is, and, you know, they might want to shrink it first and then do surgery. Okay? All right. The next one is hypercalcemia. And what we see this one in is bone metastasis, this type of cancer, because the calcium is leaving the bone. All right, so that leads to hypercalcemia. All right, guys, this occurs in a lot of patients with cancer. Don't get hypocalcemia and hypercalcemia mixed up. All right? There's a difference. Y'all know when y'all talk about metabolism and you talk about somebody getting their thyroid removed, what does that do? Is that hyper or hypocalcemia if your thyroid has been removed? Hypo. Hypo.
Yeah.
Right? How do you check for that? How do you check for hypocalcemia?
The Travostics and.
Yeah, the Vostex
and
and
those-
Trusos.
Yeah.
Trusos and Vostex, that's for hypocalcemia, okay? Now, don't get that confused, is what I'm saying, because that's where my mind automatically goes. I'm thinking Vostex or Truso sign, but that's not what we're looking for here. We're looking for hypercalcemia, all right? That's where the calcium has left the bones, and now we've got that in our blood, right? And it's a high level of it in our blood. Okay, and how are we going to fix that? All right? Let me tell y'all the number one thing that's going to fix that is fluids. All right? They need a lot of fluids. And these folks, some of the things I wrote down as far as some of their signs and symptoms, if they have too much calcium, would be deep muscle weakness. Okay? Because y'all know how the muscles are affected by the calcium level, right? And then paralytic ileus, dehydration, and that's why those fluids are so important. It can lead to dehydration. So we need to make sure we push those fluids. And you know what? They can also have some cardiac changes as it relates to too much calcium. They can do dialysis on these people as well. But I think what you need to take home from this, making sure that they have plenty of fluids. Make sure that you assess for that muscle weakness. But don't get it confused with hypocalcemia. All right? Just don't. All right. The next one is the superior vena cava syndrome. And this is where there is a tumor, you know, that's present on the superior vena cava. And how does that affect our blood flow?
It's going to cause a backup from above the heart, so
That's
you're going
right.
to end up with risk for intracranial pressure and
There you go. So it's blockage to the upper part of our body, to our brain and so forth, right?
For
It's going
draining.
up. And so what kind of cancers might contribute to a tumor that would affect the, you know, the superior vena cava going in this direction?
lung, thyroid,
That's right.
mouth, throat.
Okay, somewhere upper body, like the lung. Could be a lymphoma though. Could have a lymphoma. Blood kind of cancer. But either way, it's blocking that venous blood flow up to the upper part of the body, like the neck and the upper trunk, head. Okay? And people will, you know, with that, when you're blocking that blood flow, they may have their face may swell, neck swell. There's a picture in your book, I think, of a person that has this. So y'all need to think about that. Okay? Think about it. Look at your picture in your book. Because their neck gets swollen. Okay? Alright. Sorry I don't have a picture. Y'all gotta look it up. Alright.
Oh, wow.
They can also have a nosebleed, you know, as a result of this obstruction of this blood up here. Okay? All right, treatment for that would be some corticosteroids as well. And they may do some radiation to the mediastinal area right in here. They don't usually do a whole lot of surgery to correct this, but they may do some, like I say, some radiation. All right, the next one that's listed on my list here is Tuckerlysis Syndrome. I'm hoping I don't miss anything. On the Tuckerlysis Syndrome, the bottom line to this one is that when we are giving a person some chemotherapy to be able to kill off all those bad cancer cells, what happens is a lot of times when we kill them fast, it causes a lot of buildup of toxins and damaged cells and all to accumulate in the blood. All right? So they call that tumor lysis, which means that tumor's being destroyed. And it's building up in that bloodstream faster than the body can get rid of it. You see what I'm saying? And so this causes a person to have some issues, and two of them is hypercalcemia. You know how cells have potassium in them? Okay? And you know when they break them up, you know that cells, that potassium's released, you know, they get hypercalcemia. And then another one that they have, because all of this has to go through those kidneys, is they have hyperuricemia. And that makes sense, right? All right, so what we're going to do for this one's fluids. All right, and we're going to try to take as much potassium out of their diet as we can. So increase fluids on this one and decrease the potassium in their diet. They may give some diuretics to increase that urine flow to get some of that stuff on out of the body. And they may give some allopurinol to get rid of some of those, that build up of that uric acid or the purines, whatever, that's going through those kidneys. Do y'all know what they could give to treat the hyperkalemia? What will take potassium back in the cells?
Sodium.
Insulin. Insulin will help to get some of that potassium back in those cells. And also, they can do dialysis as a last resort. Okay? But y'all, I'll give you a lot of high spots there, and on your little handout here, it speaks to you about the high spots as well. All right? But y'all got to understand a little pathophysiology in order to understand like potassium coming out of the cells, and the insulin helps to get back in there. Okay? Y'all just kind of have to understand those kinds of things. All right, so we've talked about the oncologic emergencies. And there again, like I say, it's here. All right, let me look here. I'm going to go through my stuff real quickly because I don't want to miss anything, and I have a couple of speakers on to speak. All right. On your PowerPoint that you have, all right, we have talked about you know, the fact that people get different treatments for cancer. Okay? Now, we didn't go into a whole lot of detail about the radiation. We did talk about the chemotherapy quite a bit. All right, so we talked about the importance of surgery, and, you know, it's always been probably one of the mainstays. All right. Let's look right here, what have I got? Okay, we did talk about how anybody that gets a radiation to the throat or the neck or has a radical neck, we mentioned that, about how that can affect the salivary glands. Like he mentioned, you know, it can cause tooth decay as well. And we talked about depending on where the person has the tumor, as to how they're going to do radiation for these folks and where they're going to target. that tumor, and that's an individual thing. But once they determine where they're going to give that radiation, that's where they're going to continue to give that radiation. Now, I have been to the radiation department there at Singing River Hospital, and I went through that just so I could educate myself a little bit better about this. And what they do is, like, if a person needs to have the external beam radiation, they're going to make a little thing to put on them that they will bolt down on that table, so that every time that patient gets that radiation, they're going to zap that at the same spot. So it's kind of like a mask, you know, of their upper body or wherever they're going to be targeting that radiation. So that's interesting to see. So they have to be precise, and they have to make sure that they give it in the same place each time. But they also have what we talked about, that's called teletherapy. We talked about they have internal seeds. We mentioned that. And, you know, they're about, and it shows you in your book, they're about the size of a grain of rice or a little lead pencil. You know, they're small, that they put inside, like to treat prostate cancer or maybe even cervical cancer. And they stay there, and eventually they are not radioactive anymore, okay? And they're not going to cause a problem with somebody that's near them. One thing I did want to back up and say to you, if you have somebody who has the external beam, we have to be very careful about how we teach them to take care of their skin, all right? Because they need to not really rub it or scrub it really hard where they've had this radiation, because it can damage skin, all right, where it's given. And it can damage anything in its path to wherever it's going as well. But they don't need to use any kind of abrasive soaps on their skin. And one of the most important things that they need to, or we need to teach them, and they need to not do, is expose this to the sun. They don't need to expose their skin to the sun. And they need to follow that rule for about a year after the treatment. So you need to remember that, okay? Another thing we mentioned briefly was the I-131. Now that's an internal, which is the brachytherapy. And what they do, and I asked those questions myself about the I-131, where they give this oral pill that these folks take that shows where it glows, where they have tumor cells around their thyroid, okay? And one of the things we need to remember to tell our patients about that one is that if, you know, after they've had this treatment, that they're going to be radioactive for about 48 hours. And so we have to make sure nobody uses their bathrooms, okay? Because it comes out through their waste products, okay? Either the urine or the feces. So we have to make sure we let patients know that, so nobody goes in their restrooms, you know, for 48 hours. So they try to make sure of that, okay? So they know y'all follow me? Mm-hmm. Okay. So y'all can read about that as well. Let's think of something else. Like I say, eventually these things that they implant, like in the prostate and this too, will go away. Let me think what else we might want to talk about. All right. If you've got a patient who has one of these sealed isotopes, like if they put it in a cavity or something and the patient is, say, in a hospital room, which they don't do a lot of this anymore. I ask about this. They usually do a whole lot of this in the radiology department, and they keep these folks there until they take out these sealed, I guess, containers. You know, they'll put them in some kind of specialized little container, and when they put them inside the cavity of the individual, they try to keep them inside radiology in this lead sealed room, all right, so that nobody gets exposed to that. However, in the old day, whenever, and it still may be in some places, that they will have patients that will have one of these things inside them that are radioactive, all right? And if they do, then they have to have some kind of shield in that room, or one of these aprons that these folks wear, right? Like if we were taking care of somebody who had one of these in there, that they would have some sort of way of preventing us from being in close contact with that radioactive implant. And also, they're going to limit how long a nurse can stay in and take care of this individual. They also wear these little dosimeter things that will let them know how long they've been exposed to this radioactive material. So there's a lot involved in this. So that's why they're not doing it as much as an inpatient anymore. So they're trying to do as much as they can, because they may insert this isotope, if you will, in whatever little container they use, and try to remove that before that individual leaves the hospital, so they don't have to deal with that. Okay? But in the event that you were taking care of somebody who had one of these radioactive implants in, and it fell out in the bed, okay, then what would happen there is they would have a lead container of some sort already in that room in the event that that happened, with long tongs so nobody would be touching it, okay, that would be able to put it into that, and then they'd call the oncology people and the safety officers and all those folks to come retrieve it, okay? So there are things, and this speaks to that in your book, okay? All right, we talked about chemotherapy quite a bit. Do y'all have any questions about the chemotherapy? I think we pretty well covered most all of that. Wearing the PPE, the proper PPE, like the eye protection, you may have to double glove, you know. If a patient asks you a question about why you're wearing all that stuff, what would you tell them?
To protect yourself.
Huh?
To protect yourself.
Okay? To keep, you know, you from getting those drugs. They're not meant for you, right?
Mhm.
They're meant for the
The patient.
individual that you're giving them to. So just let them know, I have, you know, I don't need your drugs in me. Okay, so I have to make sure I don't get those drugs. Okay. Let's see what else. All right. I'm looking here to see what else we hadn't talked about. As I said, your little key points is going to address a lot that's on this PowerPoint. I'm just glancing through this PowerPoint, y'all, just to make sure we've covered stuff. And we talked about the extravasation, right, or the infiltration of the IV, and how important it is for us to continuously check on that at least every hour. I think that said 30 minutes to an hour on your sheet here, but at least every hour. And then we talked about side effects from the chemotherapy. We talked about the xerostomia, the dry mouth. We talked about the mucositis, which is could be sores inside the mucous membranes. What else? Let's talk about that for just a second. If you've got somebody who does have these sores in their mouth, what's some important things that we want to do for them?
Soft toothbrush.
Soft toothbrush. What else?
The mouthwash stuff.
Okay, what kind of mouthwash?
Something with like saline stuff with salt in
Okay,
it
so
to
in
help.
other words, saline rinses.
Mm-hmm.
Okay, we can do, like you said, soft toothbrush, saline rinses. Okay, what else might we give for a person that has that?
Why don't you give
The
them,
magic mouthwash.
Okay, what's that?
With the Benadryl and all that stuff, the lidocaine that's in it, to numb it.
Okay, do they swallow that?
There's one that they can, and then the rest of them.
Okay,
The
okay, so,
Chlorhex, the swish and spit.
yeah, that's what I'm thinking, the
Chlorhexidine.
swish and spit. I mean, it all probably does the same thing, right?
Yeah.
But the bottom line is something like that. You know, the swish and spit, okay? But warm saling's always good. Soft toothbrushes is always good. What else might we think about with these folks? There's one other thing I've
No
got.
spicy food, soft food.
Okay, you gotta think about
Hot
the
to the
food.
temperature.
That's right. You gotta think about that. Because the temperature of that food, you know, has a lot. Would you give somebody really hot food?
No, because they
Would you
already
give
got
them,
sores.
you know, really cold? Maybe
No.
not, right? So the main thing would be to give them a room temperature kind of food. So I think y'all hit on most of the things there. Okay, and then of course you don't want to let them use mouthwashes that have alcohol or, you know, really mouth. The warm saline, like you say, is probably the best thing. Okay, so it's important for them to do good oral care, and yeah, I think we've covered that good. All right, so there, when it comes to chemotherapy, y'all know we talked about y'all run out of time. Appetite, things like that. You have to be cognizant of that, and if they give certain appetite enhancers, you know, for these folks that don't have, you know, after they've been on that chemo, y'all know how it is. We talked about the nausea, vomiting. You even made mention of the metoclopramide, which is the Reglan, you know, making sure that that might help with their nausea. And I wrote a note here just for information about, you know, treating nausea and vomiting is a priority for these folks because it can lead to the dehydration and electrolyte imbalance like we've already talked about. Plus the fact that do y'all know this Megace? Have y'all seen that? Megestrol? You know, they give that for treatment of anorexia as well for these folks who have weight loss and chemotherapy, nausea, vomiting. Now, we also talked about the fact that these folks have what we call myelosuppression, you know, where they don't have the bone marrow, you know, is reduced in producing its cells. And as a result of that, these folks, with their white count going down, they become very neutropenic, and that opens them up to infection, which can open them up to some of these oncologic emergencies that we talked about, right? It can even cause them sepsis and death as a result of that. And I also told you earlier that it's very important for you to remember any temperature is significant, you know, on these folks because they may not mount that response because they're immunocompromised. There may be protocols and things that are out there for people who are on chemotherapy that we have to follow. Now let's talk about the unlicensed person for just a minute. If you've got somebody who is helping you take care of these folks, what are some of the things that an unlicensed person can do to help you take care of a cancer patient?
Give them a bath,
Okay,
change their bed,
okay,
They can do oral care,
feed
can't
them,
they?
or.
okay. They can do mouth care as long as it does not include any medication. They can't do this swish and spit stuff, okay? They can do some saline rinses though. They can help with that warm saline rinses, okay? But one of the things, we just need to make sure that they do the care, all right? As nurses, y'all, this is one of the things that we have, and this is what I want you to remember, okay? Is that if you're working with a person who is unlicensed and you're responsible for their care, then you are responsible for their care, okay? And if they don't get their bath because that nurse assistant said, well, they don't feel like it, I'm not going to give them a bath, you know what I'm saying? That can be a problem, right?
Mm-hmm.
Okay, so we just have to make sure that we are in charge of that patient in the fact that we make sure they get what they need and we don't let those unlicensed people determine what they need, okay? So keep in mind, they can help you with a mouth care, they can help you with a bath, they can help you with walking them or ambulating them or whatever they can do, all right? But it's your responsibility to make sure that these people get what they need and that the nurse assistants don't allow them to get away with stuff. You know, if it's what's best for them, okay? Let's see what else. We talked a little bit about the soft toothbrush and things like that. And that would also, what's thrombocytopenia?
Less
Low
than.
platelet count.
Low platelet count. Okay, that's what I want you to think about. All right, and if these folks have thrombocytopenia, they have a low platelet count, what are they at risk for?
Bleeding.
Okay. All right, so when it comes to taking care of these folks, just keep in mind, you know, that safety. Safety is a number one, okay? Safety. And we also talked about alopecia. We talked about the progestins and the estrogens and the blood clots that may be related to that. Now, I have a couple of speakers I want y'all to see for just a few minutes. I know that we're fixing to have to wrap this up. But, Tabitha,
Yes, ma'am.
if you'll share with us a situation that you know
Okay.
about a person that kind of brings it, you know, all together for us. Talk to us a little bit about this case.
I have a 60-year-old male diagnosed with HIV 30 years ago. Been on his medication, so it's been, you know, in remission or whatever, no issues with that. Started having issues with the rectum area and had to go to the doctor several different times. Has had hernias, things like that. Pretty healthy, not overweight or anything. Very active in life. But he started having issues again after he done had treatment on his rectum area. And he had to go see a doctor again. And this time it turned out to be an issue. You can pass it around if you want. I was going to see if anybody knew what that was. And what kind of treatment that he might would have to have for that.
That's gonna take time for the bathroom.
What area is that?
Rectal.
It's 7 centimeters deep going in. So what you're seeing there is just the outside, right above the tailbone, basically. Kind of like where we find a pressure ulcer on most people. But this is what it turned out looking like when I seen it. He's had treatment since. They ended up having to do 5 weeks, 5 days a week for 5 weeks of radiation and chemo.
Is it anal rectal cancer?
Yeah, and his worst fear was it came from the HIV. But the doctor said that he don't believe that that's what let him get this, that it just happened. But he's had several surgeries back there for hemorrhoids and things. So it made me wonder, was there something actually already there that they just didn't see, and then it just got to this point. So, but he should be getting his last treatment this week. So, I haven't got to see it since he started the radiation. But I know the radiation goes straight to that spot like you were talking about. So he lays on his, on his belly, and he said it burns real bad. And he wears his chemo every day. His chemo's in a little, he calls it his man purse.
Okay.
But it goes into his port, and he just totes it around every day.
Yeah. Just keep
So.
watching for our next speakers.
Go ahead.
Okay, now Jonathan, as that's passing around, like I say, the reason for this, guys, is this is reality. I'm not just standing up here talking to you about radiation and chemo just because you're in school, okay? But you're going to take care of people who have radiation You're gonna take care of people who get chemotherapy. It's reality. And y'all may be the chemo nurse one day. You may be a radiation nurse, who knows? Okay, Jonathan's gonna talk to us a little bit about stem cells and how that relates to people who have cancer. Okay? Y'all give him your attention.
So, it was mentioned about the chemo drugs and how they do what's called myelosuppression, and that's the stopping the bone marrow from producing what it's supposed to. That way it can drop down your white blood count to nadir. And the one thing that is important with getting those CBCs every, I believe it's 48 hours before chemo, is if they are at nadir and they receive it, they could go into what's called bone marrow failure. And this is also a risk of all different types of chemo. One of the most well-known cases is Miss Robin Roberts. She had been diagnosed with breast cancer, was treated for breast cancer, and because of the chemotherapy, developed myelodysplastic syndrome, which is a bone marrow failure, which needed stem cell transplant. Stem cell transplants are also the primary treatment for your blood cancers and disorders. You have your leukemias, which are any blood cell cancer, which are red or white. You have your myelomas, which are your plasma base, and then the lymphoma, which is the lymph system. There's 3 types of before they get to the stem cell thing, when they're close to nadir, you'll see a lot of your patients given filgrastim. It is a granulocytic stimulating factor, and that promotes reproduction of the white blood cells. That medication is also given to donors before they give stem cell transplants, so that the body produces extra stem cells and sheds them into the peripheral blood. There's 2 major classifications for stem cells based on the donor type and the cell type. The donor type, you have autologous, which is the donor themselves, the recipient themselves banks theirs, then goes under mass chemo, and they get back their own bone marrow stem cells. Then you have allogenic, that's what I did. You can have related or unrelated, that's just another donor. And then you have syngenic, and that is actually what the first bone marrow transplant was back in '56, and that was a related twins. So identical twins are syngenic, think of synergy. The 3 types, bone marrow, which is the needle aspiration of the iliac crest, that is very rare nowadays, and this is, for people in the field, it's our biggest issue. Everyone's like, when you mention bone marrow stem cells, oh, that hurts. They haven't been doing that as a primary since 1997. 1997, they came up with peripheral blood stem cell transplants. If you've ever donated blood, it's a very similar process. More so if you've ever donated plasma. It gets pulled out, spun, you get everything else back. It takes 1 to 2 days, 4 to 6 hours each day. And then finally, they have cord blood, which is not available yet in this area. There are people working to bring it here. Once they do have the transplant, it's not done through blood, like blood administration tubing. It's done through a central line cord, and it's really cool. It's just like an IV, because when my brother had his, I walked across the hall and saw it going in, so it's pretty cool. Yeah. It takes 2 to 4 weeks for engraftment, which is for the patient's bone marrow to accept the instructions of the donor's bone marrow on how to make the bone marrow. The first 100 days are critical for infection and anything. And once full engraftment's on, they're going to have regular blood tests and bone marrow biopsy to see what level is the donor's versus theirs, and that's called chimerism. Once they have a bone marrow transplant, their blood type and all blood-related factors will change to the donors. Their body DNA will be their own, but their blood DNA will become the donors. So they're called chimera, where it's two becoming one.
How about that?
And the biggest major risk is GVHD, graft versus host. You want some because that means that it's working, but that's what their biggest concern is. And like my brother, when he had his, he'd be like, so what foods are you allergic to? Because I can't stand this. I get this weird taste. And what about this and this? Because a lot of those responses are all mediated by your bone marrow, histologic responses, and the lymph system. So all that is, transferred over. So most likely he's going to end up, well, he would have ended up allergic to copper, cobalt, aluminum, because I am.
How about that?
So it's interesting.
That is very.
That's it, zoomed down to just this area.
Yeah, thank you very much. All right, guys, let me just tell you a couple of little things, and then I know my time's gonna be up, and I apologize for that, it just took a long time. But look at those key points, I encourage you to, okay? Look at your PowerPoint that you have, and use those key points and speak to that. Go back and forth with it, okay? And go over what we talked about. Just remember fluids on those oncological emergencies, the hypercalcemia and, stuff. Remember fluids. Tumor lysis, fluids, okay? Now, on this, the last little thing I just want to make mention that I didn't get to was on the handout that you have for your, the overview of death and dying, okay? We don't have a whole lot as far as our objectives on here, but we wanted you all to have this. What is the #1 priority for somebody who has cancer, who is dying?
Pain.
Pain. Okay, as long as y'all know that. That's the take home from that one. But I do want you to educate yourselves better about taking care of people. Like we talked about the postmortem early on, but I want you to understand about how people deal with a whole lot of grief, a whole lot of the stages of dying as they're dying, okay? And I was very privileged to go when I was in nursing school here in 1974. I was able to go up to Hattiesburg and hear Dr. Kubler-Ross talk about death and dying, okay? And that was something I'll never forget. She's, was guru, on the stages of death and dying. And so in your little key points here, it does a really good job of speaking to that for y'all. And it talks about people, really needing to let go and let the people know, that's dying, that it's okay for them to die. We've all been around folks. I have everybody that tends to have a family member that's hanging on for some reason to see somebody or to finish something. And I do believe that happens. But then again, we have to educate people that, there's no reason to have that guilt and regret, okay? And then we have to think about, some people have to talk to themselves about how they feel about death and dying. And y'all do too, is what I'm saying. Y'all gonna have to deal with that. Y'all gonna have to, you can't inject your personal views on somebody else's family or for them. That's how they feel. That's their stuff. So you need to really read this little thing on that overview of what a good death is and what a bad death is. Okay, we don't have time for all that, but I think it is excellent, and you all need to really look at that. And it talks about living wills. It talks about people being under hospice care and ethical issues that goes along with taking care of people who are dying. And it also goes into talking about signs and symptoms and pain and things like that they have at the end of life. It even mentions in here about euthanasia. And we are not, as nurses, active euthanasia is not supported by most professional organizations, including the American Nurses Association. And so we're not, should not be involved in that, okay? As nurses, as professional licensed. Okay, but it speaks to that in here, and then we talked about the post-mortem care. Now, what questions do you have? Sorry, we was hard at it the whole time, trying to get through it. But I know this is later on down the road, guys.
There's Miss Bates.
And what we're gonna need to do is, I know y'all got a test coming up this week, and y'all not gonna think about this oncology right now. But I do encourage you all, once this test is done, don't forget oncology, because it's first on your list for the next test, right?
Mm-hmm.
And you'll be forgot all these little things that we talked about today. So make sure you get those key points. Use them to answer your PowerPoint, because it goes along with it. All right? All right, what else? Anything? I know that y'all kind of want me to talk about the integument for a minute. I'll let her in just a minute. Do y'all have any questions about that integument?